In today's class, first we'll be going through general surgery followed by vascular emergencies. The first topic what we are seeing is appendicitis. Appendicitis is a clinical diagnosis. What is the classical presentation of appendicitis? The classical presentation of appendicitis is the pain first will be around the umbilicus. This is mainly because the anatomical distribution of the nervous system is around the umbilicus. So the midgut, it represents, midgut is nothing but appendix which comes in midgut, and dermatomal distribution of the midgut is at the T10 level. T10 level is nothing but umbilicus. That's why initially the pain will be around the umbilicus. Later on, when the umbilicus enlarges in size, it causes local peritoneal irritation. That's why the pain moves from the umbilicus to the right lower quadrant. Right lower quadrant. So this is a classical history what they present with. In examination, what you'll be seeing, in examination, when you palpate the right lower quadrant, they'll be having tenderness. When you do a deep palpation and lift it up, they'll be having a pain that is known as rebound tenderness. There is something known as rowing sign, which is quite specific for appendicitis. What is rowing sign? Rowing sign is when you palpate, that is, do a deep palpation on the left lower quadrant, the patient will be having pain in the right lower quadrant. That is known as rowing sign. Suha's sign is nothing but contraction of the Suha's muscle will elicit tenderness or the pain. It is not very specific, but can be seen in appendicitis. Sometimes the presentation might be atypical, especially in children's or in elderly individuals. It might be very late presentation. It might be very atypical presentation. In pregnancy, because of the gravite uterus, the appendix might be pushed downwards and the pain might be more in the pelvic region. Again, it will be atypical. You need to be aware that if the appendix gets perforated, the fetal mortality will be on the higher side. It can cause fetal mortality if the appendix gets perforated. Abnormal position. Most of the time, the position is retrocecal. That means behind the cecum, the appendix is present. Sometimes it can be in the pelvic region. Sometimes it can be periareal region. So it can be in different positions. But most commonly retrocecal. If retrocecal, you have the classical presentation. If it is not retrocecal, the pain might not be very classical. Women of childbearing age have various differential diagnoses because of the sexual organs, especially because of the fallopian tube and the ovaries. There are various tubo-ovarian pathologies you need to keep in your mind. What happens when the appendix gets perforated? Why does appendix get perforated? What is appendicitis basically? Appendicitis is nothing but inflammation of the appendix. Usually occurs because of the fecal impaction there. So over the time, it enlarges in size because of the accumulation of the pus. And because it enlarges in the size, the wall of the appendix can get thinned, resulting in perforation. If it gets perforated, the pus gets spilled into the peritoneal cavity and causes inflammation and infection of the peritoneal cavity. That is known as peritonitis. So whenever they mention in the stem of the question guarding or rigidity, think of peritonitis. One of the causes is perforation of the appendix. There are many other causes. So anything which causes spillage of the GI tract into the peritoneal cavity will result in peritonitis. For example, peptic ulcer, perforated peptic ulcer can cause peritonitis. Similarly, diverticulitis, a perforated diverticulitis can cause peritonitis. So there are various causes for peritonitis. So remember, guarding and rigidity, if they mention there is some peritoneal irritation is present, that's why the patient is having guarding and rigidity. As we said, clinical is a diagnosis. We have the classical presentation. Sometimes it might be difficult in a clinical setting to make a diagnosis. That's why a scoring has come up known as avocado score. Avocado score will help you to decide whether this is an appendicitis, high possibility, or a moderate level of possibility, or a low risk for an appendicitis. If it's a low risk, you can plan to discharge him. It will by safety netting. If the pain still persists, do come back. If you have a high grade fever, do come back. That is basically a safety netting. You can do a safety netting and ask them to come back. If it is a moderate or an high risk, you admit them. Moderate. Basically, what we do, we admit under the surgeon. Surgeons perform serial examinations. If required, they get NCT scan done so that they get a proper diagnosis. A high risk, usually we admit under the surgeons so that they can operate on them directly. We do not get a scan done. So remember, appendicitis is a clinical diagnosis for us, for emergency physicians in the emergency department. We do not depend on any radiological findings or any radiological investigations like a CT scan is not done in UK. You are At the maximum, you will be doing an avocado score. Depending on the avocado score, you will decide what next to be done. Let us see avocado score. Pain, which is a typical pain which is migrating to the left iliac fossa or the left lower quadrant, gets 1 score. If the patient has reduced appetite or loss of appetite or ketones are on the higher side, suggestive of dehydration, 1 point. Nausea and vomiting, another point. Tenderness in the right iliac fossa gets 2 points because it is very specific for appendicitis. Rebound tenderness, 1 point. A temperature which is more than 30, more than or equal to 37.3 degrees Celsius. WBC counts more than 10,000 or neutrophils, that is on the differential count, the neutrophils is more than 70%, 1 and 2 respectively they'll be getting. You will be adding it up. Between 5 to 6 is possible. Here is the possible. Then anything more than 6 is high risk. You need to admit those patients and need to get an appendectomy done. Lower risk, that is score less than 5, you can plan to discharge them. What we do in the emergency department, now you're suspecting an appendicitis, what you do? If the patient is hemodynamically unstable, then fluid resuscitation might be required. He usually presents with a pain, so you'll be giving some amount of analgesia. You're planning for a surgery. It is best you keep the patient nil per oral NPO. Then you'll be involving the surgeons. You might have seen here the antibiotics I have not mentioned. It is specifically appendicitis. You are not giving any prophylactic antibiotics in the emergency department. We give antibiotics only if there is an perforation. Otherwise, you're not giving antibiotics. So only if there is a perforation suggestive by presence of guarding and rigidity, then only you will be giving antibiotics. Otherwise, do not give antibiotics. Cochrane's review is basically says that giving antibiotics during the surgery prevents post-operative wound infections and abscess formation or decrease incidences of post-operative wound infection and abscess formation. It doesn't say you need to give prophylactic antibiotics in the emergency department. This is in the operation theater you're supposed to give it. So the take-home message here is do not give antibiotics for appendicitis unless it is perforated. That is a complication of appendicitis. Bowel obstructions. A small bowel obstruction can be there, a large bowel obstruction can be there, or it's just a functional bowel obstruction. What is functional bowel obstruction? Functional means there is no peristaltic movement. These patients do not have a peristaltic movement. That's why we call it as a functional bowel obstruction. Here, there is a mechanical obstruction. So this is a mechanical obstruction what the patient is having here. What is the most common mechanical obstruction which can happen for a small bowel? It is the adhesions. Adhesions usually happens because of the previous history of surgery or previous any infections of the abdomen can cause adhesions. Followed by hernia is the second most common cause for bowel obstruction. In large bowel obstruction, tumors is the first or the most common cause for bowel obstruction. Followed by there are various like volvulus can cause, adhesions can cause, but most common is the tumor, what you need to remember. What are the signs and symptoms of an bowel obstruction? Bowel obstruction, what happens? For example, here, there is an obstruction, what you can see here. If obstruction is there, what you have eaten will come here and gets obstructed and starts accumulating. Because it is getting accumulated, the abdominal wall gets, that is nothing but the intestinal wall gets dilated. Once it gets dilated, there is reverse peristalsis because the foot cannot move downwards. It will go in the reverse direction and results in vomiting. That's why these patients will present with a vomit. As this bowel is getting distended, the neurons get stimulated and the patient will start having pain. This distension itself will cause eventually the abdominal distension. You can see it. As nothing can pass downwards, the patient will have constipation. Over the time, what happens as it is stretching and stretching, once it's like a balloon, if you stretch and stretch and stretch, it can perforate at any point of time because the wall gets thinned. If it perforates, you have peritonitis, which can appear in these patients. Bowel ischemia is compromised blood supply. It's a broad term. Bowel ischemia is a broad term. Compromised blood supply, basically it means. So a compromised blood supply can result because the bowel wall is enlarging, which can cause constriction of the vessels which are innervating this. Because it is getting enlarged and enlarged, it can cause pressure on the blood vessels, resulting in bowel ischemia over the time. It's a rare complication. Peritonitis or the perforation is the most common complication what you can encounter if you leave it for a longer time. On an X-ray, how to differentiate it? It is important it is tested in the examinations because an unstable patient, you cannot shift it out of the emergency department to get a CT scan done. Usually, the best initial test is to get an X-ray done. It is very easy to get it done. Minimal radiation exposure, what you're having, and it is cost effective. So whenever you're suspecting an bowel obstruction, it's better to go ahead with an X-ray done. It's easier. You can easily differentiate between a small bowel obstruction and a large bowel obstruction. What do you see in a small bowel? Small bowel is more centrally located, what you can see here. So it is centrally located. Compared to the large bowel obstruction, it is more peripherally located. It is closer to the abdominal wall, the large bowel. Along with it, the small bowels, the diameter is less. Usually it is significant if it is more than 3 centimeters, you will take it quite significant. In large bowel, if it is more than 5 centimeters, you take it quite significant. Hostras are present. What is hostra? If you see closely here, you can see this white color line. It is only till here, till the midline, and here it is there. This is not completely across the bowel wall. This is known as hostra. Compared to that of the small bowel, in small bowel, what you see is valvulae conventis. Valvulae conventis is nothing but, again, it is an horizontal whitish color line on an X-ray, which is seen across the bowel wall. Across it, complete diameter, it is seen. Complete diameter, what you can see. Complete diameter, you can see. That is also another differentiating factor, what you need to remember. How sensitive is it to pick it up? It's quite sensitive. Around 70% it is sensitive to pick it up in a small bowel obstruction. It is as sensitive as 90% to pick it up in a large bowel obstruction. In large bowel obstruction, one of the large bowel obstruction causes is volvulus, which we have recently learned now. Sigmoid volvulus can be differentiated from an celiac or cecal volvulus. Sigmoid volvulus classically takes up an coffee bean appearance. This is also also known as U-shaped bowel loop. Coffee bean appearance, you can see it looks or it resembles quite a bit like a coffee bean. And usually it goes and settles down in the right upper quadrant, but it can be on the left upper quadrant also, as you can see in this image. What about the cecal? Cecal is basically a one dilated loop. It can be anywhere in your abdominal cavity. Distal to any obstruction, always remember the bowel will be empty because nothing can pass through it. So distal to it, it will always be empty. Bowel always will be empty. Functional bowel obstruction is typically seen in both small and large bowel. So it will involve the both small intestine as well as the large intestine. CT scan is preferred. Whenever you're getting a CT scan done, it is the CT scan with IV contrast what is preferred, not in plain CT scan. Plain CT scan will not give you much of the findings. You will not know exactly what is causing the obstruction, at what level it is causing the obstruction. That will not help you to determine the management plan. So whenever you're planning to get a CT scan done, always get an IV contrast CT scan done. So whenever you're giving an IV contrast, make sure you get the creatinine levels done because it affects the kidney. If someone is having a high creatinine levels, it can predispose that patient to a complete renal failure. So be aware when you're using an IV contrast, get an creatinine done before that. Along with it, routine blood investigations like full blood count, coagulation profile, UNE, and electrolytes will be required because he's constantly vomiting and he's constipated. There is signs of infections also present. For that reason, full blood count, urine, creatinine, electrolytes are required. Coagulation profile mainly because these patients, if goes for the surgery, you need baseline INR, PT, APTT levels are required. How do you manage these patients? Fluid resuscitation if required. For example, if the patient is hypotensive or dehydrated because of recurrent vomiting what the patient is having. Usually they present with pain, so give them analgesia. Antiemetics. When do you see vomiting in the person? Vomiting you see whenever there is a small bowel obstruction. You do not usually see in a large bowel obstruction. In a large bowel obstruction, if the patient is having vomiting, it basically suggests that cecoileal wall is present between the ileum. If this is the cecum and this is the ileum, what you're having, there is a wall here. If this wall is not functioning properly, then the small bowel also get distended, resulting in vomiting. Otherwise, in large bowel obstruction, you usually do not encounter and vomiting. It is in the small bowel obstruction you see and vomiting. So what we usually do is we try with an antiemetic. If that is not effective, then we go ahead with an nasogastric tube, Ryle's tube or nasogastric tube. It's one and the same. What we try to do, the bowel is distended here. So for example, this is the bowel which is distended here. So you place the NG tube and try to aspirate all the air and the food particles what are here. This will cause compression of the bowel. Compression of the bowel will bring down the vomitus because there is nothing there. It's a dilated bowel which causes reverse peristalsis. So if you can just decompress it by putting a nasogastric tube, that will help a long way to just control the vomiting and make the patient feel better. What about enema? Increase the bowel movements. that might push the foreign object here, what is there, which is obstructing here, and might relieve the obstruction. It's a good idea. The problem here is what happens if you increase the peristaltic movements. The peristaltic movements increases, here is the obstruction what you are having. If this obstruction doesn't move and pass, then because of increased peristaltic movements, chances of perforation increases. So it is a double-edged sword what you are having that. So do not give enema without consulting the surgical team. Always consult the surgical team. If they recommend, then you document, then only give it. Do not give it on yourself. Surgical reference for further management, obviously, because they need to remove the obstruction what is present there and restore the normal cavity what is there, so that bowels, the food particles what you're using can get digested and move through the bowel cavity. Small bowel obstructions are usually treated conservatively. Nil per oral, give some IV fluids. Over the time, it gets resolved by itself. A large bowel obstruction most of the time will require an operative intervention, but this decision is always taken by the surgeons, not by us in the emergency department. All these patients requires an admission. You are not discharging any one of them. Bowel perforation. As I told you, there are various causes for bowel perforation, from peptic ulcer, appendicitis, diverticulitis, carcinoma, stroma, toxic megacolon, which we have learned, which is one of the complications of ulcerative colitis or inflammatory bowel disease. Strangulated bowel can cause perforations. These are the few examples what you have mentioned here. What happens if bowel is perforated? If bowel is perforated, we swallow around 1.5 liters of air per day, minimum, what I'm talking about. So this air is there in your bowel cavity. So this air gets entered into the peritoneum. If it is entered into the peritoneum, as air is light in weight, it goes and settles up. Usually, you will see a dark color between the diaphragm and the liver. This is very much suggestive of a bowel perforation. This is known as air under the diaphragm. This is air under the diaphragm. Do not see the opposite side. That means do not see below the left side of the diaphragm, because you might get confused with the fundus. So this, what you're seeing, is normal. It's a fundus. This, what you're seeing, is abnormal, absolutely abnormal. Few times you might get confused with the bowel perforation in the patients who have recently got an laparoscopy done. In laparoscopy, what they do is they distend the abdomen by placing the gas inside the peritoneal cavity so that they can easily visualize. Okay, what they do is they put a probe here within camera, another probe to operate, another probe to just insert the gas into the peritoneal cavity. So soon after, like 24 to 48 hours after an laparoscopy, if you get an erect abdominal X-ray done, then it might show air under the diaphragm. You might get confused with the perforation. You cannot depend at that point of time. That is the only time you cannot depend. Otherwise, it is an perforation until and unless proven otherwise. There is one more sign what you can see. It is known as Wriggler's or double bowel sign. What happens if the air is outside? If the air is outside, you can see air inside the bowel loop and outside the bowel loop. So on both sides of the bowel wall, you can see the air. As in the arrow, what you can see, air is seen inside the bowel loop, outside the bowel loop. So black color, air appears black. So inside, outside, you can see. Similarly, here also you can see, here it is inside and outside also you are seeing it. This is known as double bowel sign, also known as Wriggler's sign. It is also very specific for an perforated bowel. Ultrasound is not very helpful at all. Do not get an ultrasound scan done. Whenever you're planning to get NCT abdomen done, get NCT abdomen done with an IV contrast, not an oral contrast, IV contrast, which is preferred. Remember that in emergency department, it's always IV contrast, which is preferred than an oral contrast. What is the treatment? Now your bowel is perforated and all the food materials, sometimes even fecal matters, have spilled into the peritoneal cavity. Chances of infection is very, very high. So you need to make sure this patient gets broad spectrum antibiotics. So antibiotics are given here because the bowel is perforated. Do not forget that. Other are symptomatic treatment like fluid resuscitation for hypovolemia. Intravascular analgesias might be required. Severe pain will be there. Antiemetics might be required. Keep them nil by oral. Do not give anything by oral. They require an surgery. Urgent surgical reference is required for an surgical repair. Mesenteric infarction and ischemic colitis. Do not get confused between these two terms. Okay, usually what happens? Ischemic bowel. Ischemic bowel is an broad term. Anything which compromises the blood supply to the bowel is known as ischemic bowel. Causes for the ischemic bowel, for example, it can be a mesenteric infarction. Is one of the causes for, sorry, ischemic bowel. Mesenteric infarction is one of the causes for ischemic bowel. One other cause is ischemic colitis. Another cause, what we have recently studied here, is an bowel obstruction. So there are various causes for reduced blood supply for bowel. So ischemic bowel is a broad term. Inside that you have mesenteric infarction, ischemic colitis. Remember that mesenteric infarction is different from ischemic colitis. What happens in mesenteric infarction? Mesenteric infarction are embolus or thrombus or an profuse hypotension or mesenteric venous thrombus. What happens? Basically, there is a thrombus. There is a clot which is present. Where is the clot present? Most of the time, the clot is present in a superior mesenteric artery. Why not in any other artery? Why most of the time it is in superior mesenteric artery? Mainly because in an abdominal aorta, the first branch is the celiac artery. As we are aware of, first main branch is the celiac artery. Celiac artery is almost 90 degrees to it. So something passing down, how likely it will pass into the 90 degrees like this? Unlikely. If you go to an SMA, that is superior mesenteric artery, it is more obtuse angle what is there. So a clot which is there or a thrombus which is there, easy to pass here and cause an obstruction. That's why it is mainly seen in superior mesenteric artery. If a superior mesenteric artery is involved, what will happen? It will cause a complete obstruction, no bowel supply to the, no blood supply to the bowel, resulting in ischemia, eventually will result in infarction. Infarction means that part of the bowel is dying. A dying, whenever there is an infarction, there is a part of your body which is dying. It can be a myocardial infarction. It can be a bowel infarction. So mesenteric infarction, a part of your bowel is dying. It cries for help. You can cause it. That's why it causes severe pain. This patient presents with acute severe pain. They'll be literally rolling on the bed when they present to the emergency department. But when you examine these patients, hardly you will get any signs. The abdomen might be soft, non-tender, no guarding, no rigidity. The examination seems to be fine. It doesn't correlate your examination with the clinical findings or the presentation what they have. He has a severe pain, but the abdomen is completely fine on examination. What is this? You need to start thinking of mesenteric infarction because this part of the muscle is dying. It doesn't have any blood supply. That means it doesn't have any oxygen being supplied to that part of the bowel. What will result? Results in anaerobic respiration. Anaerobic respiration results in production of lactate. So accumulation of lactic acid is seen. So serum lactate levels will be very high. So take-home message is severe abdominal pain. Abdominal examination is almost normal, or there might be guarding and rigidity, doesn't depend. Severe abdominal pain with an high lactate levels like around 4, 3, 4, or anything more than 3 you're suspecting, 3 or more than 3 you need to suspect a mesenteric infarction until and unless proven otherwise. CT angiography is the best investigations what you can get it done. A broad spectrum antibiotics needs to be given in this individuals because this is going infarcted. So it is dying, gangrenous changes can appear and it can perforate. So their chances of infection is very, very high. You will consider giving heparin, but you're not giving heparin. You'll always consult with an vascular surgeon. You'll be consulting with an interventional radiologist and decide on what management plan, whether to start an heparin infusion, or they want to do an endovascular thrombolysis. They want to do that revascularization options will be decided by either by a vascular surgeon or by an interventional radiologist. Contrary to what you have learned in a mesenteric infarction, there is a differentiating factor between an ischemic colitis. Ischemic colitis occurs where there is chronic, remember that this is chronic, that was acute, chronic arterial insufficiency is present. Most of the time, this is seen in watershed territories. What is watershed territories? When an area is supplied by two different arteries. For example, this is known as splenic fissure. This area, what you're seeing, is known as splenic fissure. Up to here, that is almost 2/3 of the transverse colon is supplied by superior mesenteric artery. After that, around descending this whole part till here, it is almost supplied by inferior mesenteric artery. So this is a gray area in between where small terminal arteries are supplying both from the superior and inferior artery. So the bowel supply is not that great there. Over the time, especially in elderly persons who develops an atherosclerosis in most of the vessels, eventually they'll develop atherosclerosis, especially in terminal vessels of the superior and the inferior mesenteric artery. This area that is known as splenic fissure is the watershed area, results in starts having an ischemia. Unlikely to go into an infarction, starts having ischemia. Due to the ischemia, chronic ischemia, the bowel lining will start dying first. If you start dying, there is some amount of blood which gets mixed with the stools. So the common presentation is abdominal pain and stools which has blood in it. That is the common presentation what they present with. So blood stools, sometimes it might be loose stools what they'll be having it. When you get an X-ray, especially when you get an barium enema, then you can see this. This is known as thumbprint signs. That is a classical finding. What you can see may not be seen always, but that is a classical finding. What you need to look out for. Again, you need to involve the surgeons here. Complications like stricture formations and gangrenous ischemic colitis can happen. It is a very late complications what we'll be having. Very much similar to it can present is a diverticulitis. First, let us see what is diverticula. Diverticula is nothing but pouches. What you see in a large intestine is known as diverticula. If this pouches gets obstructed and gets infected, then we call it as in diverticulitis. Itis is inflammation. Inflammation is because of the infection. Infection is because of the obstruction of the diverticula. These pouches can be seen in many individuals, especially in middle age to the elderly age. Pouches can be seen this, but it is not always diverticulitis. Diverticulitis is that pouch needs to get infected. What is the NICE guidelines? What does the NICE guideline recommend and how to make a diagnosis of a diverticulitis? Diverticulitis is a patient who presents with a constant abdominal pain. Most of the time, it will be in left lower quadrant. But be aware that in the Asian origins, it can be in right lower quadrant. Also, someone from an Asia, it can be from right lower quadrants, especially from the China side. That side, they can present with the right lower quadrant. Do not get confused. Along with a constant abdominal pain, it's a constant, they will have a fever. If they do not have a fever, at least there should be changes in the bowel habits, either constipation or the loose stools. Most of the time, loose stools, sometimes associated with some amount of mucus or the blood in the stools. And, or there should be a tenderness in the left lower quadrant, or there should be a palpable mass, or there should be a history of diverticulitis, diverticular or diverticulitis previously. So our previous history of diverticulitis, or the patient has an palpable mass in the left lower quadrant, or the patient has tenderness in the left lower quadrant, or there are changes in the bowel habits, or the patient has a fever. So any one of this following, along with the abdominal pain, if they present to the emergency department, then you need to suspect an diverticulitis. This presentation might overlap with the presentation of an ischemic colitis. Whenever you are getting confused with an ischemic colitis and diverticulitis, remember that diverticulitis is the more common one. Pick diverticulitis over an ischemic colitis. Ischemic colitis, usually the patients will be sick when they present to the emergency department. What we need to do if you're suspecting a diverticulitis? See whether the patient is systemically well. If the patient is systemically well, no antibiotics is required. Ask them to come back to the emergency department if they develop symptoms. Okay, so symptomatic treatment you are giving, like a painkiller you are giving, tell them to have a high fiber diet, take few painkillers that should be sufficient. You will suggest them and discharge them. If the patient is systemically unwell, what do I mean by systemically unwell? For example, the patient is having tachycardia, hypotension, suggestive of sepsis. You consider this patient as systemically unwell. Or he is immunocompromised. He might be on some chemotherapy. Or there is significant amount of comorbidities. For example, uncontrolled diabetes he is having, uncontrolled hypertension. Or he is a known case of end-stage renal disease. In those circumstances, you will go ahead and prescribe them the antibiotics. Otherwise, in a healthy individual with minimal comorbidities, you do not prescribe antibiotics. This is according to the NICE guidelines. What about imaging? Imaging also is not preferred. You do not get any imaging done in the situations. Anorectal diseases. It can be an hemorrhoid. Hemorrhoids are two different types. It can be an internal hemorrhoids. It can be an external hemorrhoids. How do you differentiate it? There is a line, anatomical line known as dentate line. Anything beyond the dentate line or behind the dentate line, it is known as internal hemorrhoids. Internal hemorrhoids are usually not visible. These bleed and they are painless. External hemorrhoids are the one which are very painful, which are visible at the anal side, which are very painful, but they do not bleed. They're not associated with the bleeding. So remember, if the patient presents with the pain, he'll not have bleeding. If he doesn't present with the pain, painless bleeding he is having, then suspect an internal hemorrhoids. Internal hemorrhoids can only be seen on proctoscopy, or you need to do a digital examination. External hemorrhoids are easy. If you ask him to strain, external hemorrhoid starts appearing. Another thing is surgical interventions is usually recommended in internal hemorrhoids. The prognosis is good. For external hemorrhoids, it is not recommended. It recurs again if you do an banding surgical wise. So you usually recommend for them an high fiber diet. Anorectal diseases, hemorrhoids, we have discussed with it. What is anal fissure? Anal fissure is discontinuation in the lining. Once there is a discontinuation in the bowel lining around this anal region, what will happen? The nerve endings are exposed. So whenever it gets a small stimulus also, for example, just opening the bowel itself will cause severe pain. And it can bleed a little bit. So there might be streaks of blood around the feces can be present. That is the classical presentation what they'll be having. Anorectal abscesses around the anal region are known as anorectal abscesses because usually we sit on our gluteal region and the perineal region and there is a lot of pressure. They will be in a lot of discomfort. They say, I cannot sit at all, doctor. It is paining a lot. As it is an abscess, they might be associated with some amount of fever, pain will be there. Pain will be there. So what we'll do, like any abscess, you need to do incision and drainage. You need to drain it, might require an antibiotics plus or minus antibiotics depending on the presentation. Rectal prolapse is not difficult at all to pick it up. There is a classical prolapse of the rectus will be there. You cannot do anything. You need to refer to the surgeons. That's the only option what you'll be having. So hemorrhoids, how do we treat it? If it's an internal hemorrhoid, surgical intervention can be done, but doesn't require acute. They can follow up on the OPD, doesn't require an admission. For an external hemorrhoids, fiber diet is preferred. What about steroids? Steroids is not recommended. Anal fissures, due to the pain what they are having because of the anal fissures, there is an exposure to the exposed nerve endings are present. The internal sphincter might go into spasm. If it goes into the spasm, the patient will have constipation, hard stools, difficult to pass, and it can worsen the fissure what they are having. Usually, GTN ointments are preferred. Glycerol trinitrate ointments will be available to reduce the spasm because of the anal fissures. That is the treatment, along with high fiber diet and plenty of fluids. Anorectal abscesses, what we discussed, again requires an surgical intervention and basically incision and drainage. Most of the time, antibiotics will not be required unless it is associated with a surrounding area which has inflammation and infection, that is basically cellulitis, or the patient is immunocompromised. Rectal prolapse, direct surgical reference. What is pinonidal abscess? Pinonidal abscess is basically instead of hair growing upwards, it grows inwards. This is the hair what you are having. Because the hair has grown inwards here, it can form a cyst and get infected. This is known as pilonidal cyst. Again, any abscesses are present, you will be doing an incision and drainage. When do we admit in a hemorrhoids? As I told you, most of the time hemorrhoids not required. But if there is a profuse bleeding from the internal hemorrhoids and anemia is symptomatic, then you might have to admit. If there is a thrombus hemorrhoid which is present, what you can do is you can small nick can be given and discharge this patient. Small nick will release the thrombus what is present there and the patient will be pain-free. You can discharge. If you're not confident to do it, then depending on the local protocols, most of the time what will be there is there will be a daycare surgical unit will be there. So you'll be referring to the daycare surgical unit. Or if that is not present, you might have to admit at that point of time for a thrombosed hemorrhoid. If it is suspected malignancy, depending on how old is it, how severe, how much you are suspecting, but most of the time, again, this doesn't require. A severe hemorrhoids causing severe discomfort might require a 4th-degree hemorrhoids, we call it. Again, more for the surgical people, not for us. External hemorrhoids, which are necrotic or gangrenous, might require an admission. But remember that most of the time you discharge these patients, you ask them to follow up with the surgeons on an OPD basis. Hernias. The main hernias, what you need to learn is inguinal hernia. Okay, inguinal hernia, you should be able to differentiate between an indirect inguinal hernia and a direct inguinal hernia. Few of the points you need to remember. There is something known as midpoint of the inguinal ligament. There is something known as mid-inguinal point. Mid-inguinal point is the midpoint between anterior superior iliac spine and pubic symphysis. That is known as mid-inguinal point. Inguinal ligament. Inguinal ligament attaches to the anterior superior iliac spine and pubic tubercle. In between the two pubic tubercle, left and right side is known as pubic symphysis. So it doesn't attach to the pubic symphysis, it attaches to the pubic tubercle. So if they say midpoint of the inguinal ligament, it is a midpoint between anterior superior iliac spine and the pubic tubercle. At this midpoint is the deep ring. Okay, just proximal to the pubic tubercle is the superficial ring. Deep ring is also known as internal ring. Okay, usually what happens during the development, your spermatic cord usually passes from here and descends down and comes out of the superficial ring, goes into your scrotum. First thing what we'll be seeing is indirect inguinal hernia. Indirect inguinal hernia passes from the internal ring, also known as bowel loops. Basically, what happens is bowel loops passes through the internal inguinal ring here and goes down into the superficial inguinal ring and can go down into a scrotum itself. This is known as indirect inguinal hernia. In a direct inguinal hernia, what happens? Directly, it comes off from the posterior wall of the canal. It bulges out from the posterior wall of the canal. Okay, and that doesn't distend downwards into your scrotum. That you need to remember. And direct inguinal hernia is mainly seen in elderly persons. This is mainly seen in youngsters. It is mainly commonly seen. Femoral hernia is very easy. It is more commonly seen in females. Femoral hernia. Females, you need to remember. And abdominal contents passes through the femoral canal just below the inguinal ligament. Whatever happens is below the inguinal ligament. Femoral hernia, very easy to pick it up. Shouldn't be a problem. Another differentiating factors what you need to be aware of between an internal inguinal ring and a direct inguinal ring is there is something known as inferior epigastric artery. Inferior epigastric vessels are the artery. Whenever there is inferior epigastric vessels or artery, lateral to it will be the indirect inguinal hernia. Direct inguinal hernia will be medial to it. That is one of the important differentiating factor what you need to be aware of. Lateral is indirect, direct is medial. Mainly because, remember this, indirect comes from the deep ring. Direct comes from the posterior wall here. So more medially is the direct one. More laterally is the indirect inguinal hernia. How to reduce it? Remember the pathway what you're having. So you need to go up, then you need to go laterally, then you need to go backwards. That's how you reduce it. So upwards, laterally, and backwards. How do you reduce direct hernia? So direct hernia has come out like this. So upwards you're going, and then you're going just backwards. So upwards and backwards is upwards and then straight backwards what you're giving to reduce it and direct hernia. There are other differential hernias also what you need to be aware of. Ventral hernias. Whenever there is a defect in the anterior abdominal wall, then you call it as an ventral hernia. Depending on the anatomical position, if it is around the umbilicus, then you call it as an umbilical hernia. Around the epigastric, then you call it as an epigastric hernia. What is Spigelian hernia? Spigelian hernia is whenever there is an hernia at the lateral edge of the rectus abdominis, then you call it as an Spigelian hernia. There's one more hernia known as obturator hernia. Obturator hernia, this cavity what you're seeing in the pelvis, this is known as obturator fossa. When the hernia comes out through this, that means the bowel loops or the abdominal contents come out from the obturator foramen, then you call it as an obturator hernia. So basically herniates from there. That's why the name comes up. The chances of perforation is on the very higher side. Richard's hernia is important, can be tested in the examination because it has a very unusual presentation. What is Richard's hernia? In Richard's hernia, what you can see is only one wall of the bowel has got herniated. Another part of the wall of the bowel is still normal. So the lumen is not affected at all. So the food particles what you are eating can easily move through the lumen. So it doesn't present with an obstruction at all. There is no obstruction what you will be having. But what happens? One part of the wall of the bowel which is herniated, over the time there can be an strangulation. Strangulation will result in reduced blood supply. Reduced blood supply will cause gangrenous changes. Okay, gangrenous changes can result in perforation. So most of the time, how do they present? They present with the strangulation, and the gangrenous changes is the most typical presentation they'll be having. They do not present with an abdominal obstruction. That is the important differentiating factor in Richard's hernia. Lumbar hernia. Lumbar hernia As you can see in the lumbar region, what you'll be seeing, herniation you'll be seeing. This is mainly, the name came up mainly because there is a lumbar triangle. You need not remember the boundaries of the lumbar triangle. It herniates, or the bowel abdominal contents come out from an lumbar triangle, and this will be in the flank region. You can see a mask in the flank region as I'm denoting here. That is the common presentation. So closer to the abdominal wall, which bowel is present? Large bowel. So it causes an herniation of the large bowel. So large bowel obstruction, whenever it is present, it and lumbar hernia. Only lumbar hernia can present with a large bowel obstruction. All these are all small bowel. Richards hernia, small bowel. Ventral, obturator, Spigelian, or inguinal hernias, all are small bowels which herniates out through these various openings. It is not a large bowel. Large bowel is only seen in lumbar hernia. Complications. Initial complication is there is obstruction. What is the obstruction? Obstruction to the fecal matter or the food particles what you have taken, it cannot pass because the narrowed space what is present here. Over the time, this narrowing what is present there can get strangulated. Strangulation of what? Strangulation of the blood vessels, especially the arterial blood supply gets strangulated. That time it can enter into an gangrenous changes. So this is known as obstruction. This is known as strangulation. There is a differentiating factor between obstruction and the strangulation. Once a strangulation sets in, you need to relieve the strangulations within 6 hours. Otherwise, it will enter into an gangrenous changes. 6 hours is mainly when the blood supply is completely gone. There's absolutely no blood supply. Usually the tissue dies within 6 hours. Holds good for a testicular torsion also. Few other things you need to be aware of. One is phimosis, another one is paraphimosis. Phimosis, if you're unable to retract the foreskin, it is known as phimosis. What is paraphimosis? A retracted foreskin is present, and it kind of causes constriction over the time because of the edema which is developed, and slowly the edema will start increasing in size. They are the two differentiating factors. This is a true emergency, what we call it. This, most of the time, it is not a true emergency. Commonly seen, unable to retract, commonly seen in children, it is seen, it might be physiological. Over the time, they'll be able to retract it. What is the most common cause here? It is the infection. It is the poor hygiene, poor personal hygiene results in this failure to retraction, what the patient will be usually presenting with. So it is a clinical diagnosis. You need not get any investigations done because you can see, visualize it, and make a diagnosis. As I told you, it is most of the time it is physiological. Sometimes it might be pathological, leading to an urinary retention or urinary tract infection or infection of the balanopostitis, basically infection of the, infection of the terminal parts of the penis is known as balanopostitis. Foreskin also gets involved and infected. So most of the time, it is the poor hygiene which is leading to the infection here. If there is an infection, you'll be giving antibiotics. Otherwise, you will be recommending them for a good hygiene. Just counsel the mother. It is seen pediatric age group. Tell them, counsel the mother how to keep in good hygiene and gently retraction of the foreskin. Over the time, they'll be able to retract and you can just discharge them. You are really worried when there is an acute urinary retention. If there is an acute urinary retention, the option might be with a suprapubic catheter incision might be there. That is one of the options. Then you'll be referring to the surgical team because there is an acute urinary retention. That means it is causing complete obstruction to the passage of the urine itself. At that point of time, circumcision is the best treatment option. So involve the surgeons. Circumcision is basically removal of the foreskin. Paraphimosis is a true emergency. As I told you before, it's a true urological emergency what you are having. There is an proximal edema which develops due to the constriction of the foreskin and they present with kind of severe pain. If you leave it as such, it can cause arterial compromise resulting in gangrenous changes. How can we reduce in the emergency department? First thing what we try is by trying the osmosis. There is an edema what is present here. You want to reduce this edema. What you will do is, gauze is soaked in sugar water. Sugar water is nothing but will pull the fluid towards it. That's the osmosis what you're trying it, and you'll wrap it around the penis here. That might reduce the swelling and eventually you might be easily able to pull the foreskin or get back the foreskin into the normal anatomical position. If that fails, you can attempt a manual compression. Manual compression is quite painful, so make sure they have good analgesia like an Antonox, local jelly, anesthetic jelly, or an IV sedation might be required. Okay, then gently apply pressure over the swelling what is present to relieve the edema what is there. Once the edema reduces, you can easily pull the foreskin back. If it is unsuccessful at that point of time, a dorsal slit can be tried or a circumcision will be required. Most of the time they do a dorsal slit to immediately relieve the distress what the patient is in. Later on, they'll follow up with a circumcision if it is a recurrent event. Dorsal slit is just slitting here. The edematous part which is there, just put an incision here, drain the edema, then foreskin will come back. Before I go into the vascular, I'll just go through the anyone has any questions through it. Ischemic colitis, usually they'll have quite a bit of pain, more pain compared to the diverticulitis. But if it is not clear cut, always choose and diverticulitis over an ischemic colitis. Ischemic colitis develops over the time, but acutely they might have very severe pain once gangrene changes, once the mucosa and submucosa gets involved. Mainly the mucous lining when it gets involved. This hernia, you want me to repeat it here? It is known as Richard's hernia. In Richard's hernia, what we'll be having, only one side of the bowel loop is involved. Okay, the other part of the bowel loop is not involved. That means only one wall is involved. As the picture is suggesting here, bowel lumen is open, so obstruction they'll not present with. Only this part is getting involved. So after blood supply is compromised, they usually present with an strangulation where gangrenous changes might have been set in. So they present on the latest type. Vascular emergencies, abdominal aortic aneurysm, one of the most important things tested in your exam, and you should be always suspecting an abdominal aortic aneurysm with any elderly person. Elderly means 50 years I'm talking about, and they present to the emergency department with an back pain or with an abdominal pain, especially the lower abdominal pain. So lower back pain or lower abdominal pain, if they present to the emergency department, suspect it can be an abdominal aortic aneurysm and go ahead and get an ultrasound scan done. What do you see in the ultrasound scan? In the ultrasound scan, we see the diameter of the aorta. Though the aorta normal physiologically at different levels, the size of the aorta changes. The main important number what you need to remember is whenever it is greater than 3 centimeters, if it is greater than 3 centimeters on an ultrasound scan, you can label it as an aortic aneurysm. Most of the time, aortic aneurysms is seen infrarenal after the renal branches have come in infrarenal, and it is a fusiform type of aneurysm which is more commonly seen. That is the more common presentation. Classically, they present, if at all classical presentation is there, which is very rare, the classical presentation to be. If at all it is a classical presentation, they can present with a triad of low blood pressure with an back pain or abdominal pain and palpable pulsatile abdominal mass. Most of the time, this classical feature is not seen. So whenever a person presents with a lower back pain or an lower abdominal pain in persons who are 50 years of age group, always do an bedside ultrasound scan and looking for the abdominal aorta diameter. More than 3 centimeters, label it as an aneurysm. Sometimes they might even present like an flank pain radiating to the groin region, very much suggestive of an ureteric calculi, but it may not be. So always do an bedside ultrasound scan for all these patients. Even these patients can have some amount of hematuria also. This is mainly seen because of the irritation of the ureter. They can have some amount of hematuria. So do not suspect this patient is having an calculi because there is an hematuria. Hematuria can also be seen in abdominal aortic aneurysms. So clinically, you will be suspecting supplemented with the emergency ultrasound scan, then you can rule it in, but it will not rule out. So bedside ultrasound scan most of the time helps to rule in, not rule out. But it is not a very classical presentation. The aorta diameter is less than 3 centimeters, then is highly, highly unlikely to be an triple A. Triple A stands for abdominal aortic aneurysm. CT scan with an IV contrast is always preferred. That is nothing but aortogram, what you are getting it done. CT aortogram is always preferred. It will show you exactly where is it and what is the size of it. Is it ruptured or it is some oozing of the blood is present? Everything can be seen, but you can get it done only if the patient is stable hemodynamically. Otherwise, you're not shifting this patient out of the emergency department. How do you manage? Like any other emergencies, it's an ABCD management what you'll be having. But there is a differentiating factor here. The normal rules doesn't apply to an triple A. The normal rule, what we do, if the patient is hypertensive, what we do, we resuscitate first before we involve or refer to the specific specialty. Here, the reversal is done. The first step is to involve the vascular surgeons here, then starts resuscitating. Why involve the vascular surgeons before? Because once it's ruptured, usually vascular surgeons will not take up because they cannot save this person. Once it's ruptured, the person will die. Once it's ruptured, nothing, no one can do anything. People with confirmed AAA having cardiac arrest or having loss of consciousness, negligible chances of surviving and AAA refer. It's a major surgery. They have to open up the entire abdomen and do a surgery. He will collapse at any point of time. An incision itself might cause a collapse for those patients. So highly unlikely that patient gonna survive. That's why first step is do and vascular, involve the vascular surgeons first. Then once they say they accepted case, yes, we will accept this case, then make sure they are shifted to the regional vascular services as soon as possible. Why I'm saying regional vascular services? Because most of the NHS might not have the vascular team available which are qualified enough to perform this surgery. So usually few of the district level hospitals will have one center where the vascular services are available. You will shift to that center. If your hospital has the center where you're working, then you need to immediately involve the vascular team and they will take over the case. Once the vascular team you're referred, in the meanwhile, they'll take the time to make a decision. Usually it will be registrar level. He'll discuss with the consultant. In the meantime, you need to start resuscitating. If the patient comes with an hypotension, that means there is oozing of the blood. Oozing, I'm telling, it is not ruptured and bleeding. If it is ruptured, he'll die. He might not even present to the emergency department. It's just oozing what I'm telling here. So cautious fluid resuscitation, aiming for the blood pressure around 90 because high blood pressure, increased blood pressure can cause complete rupture. So you're cautiously doing a fluid resuscitation. Blood is the preferred one here if available. If not, you'll be doing crystalloid fluids. Cautiously do it. Just aim the systolic blood pressure to be around 90. That is sufficient. High blood pressure, use labetalol to control it, bring it down to the normal. Whenever it is expected, whenever it is vascular surgeons accept the case, make sure they transfer within 30 minutes. Do not delay for any reason. Okay, I'm doing a resuscitation, I'm doing a blood transfusion, wait. No, there is no point in waiting because if it ruptures, he will die. Every second matters. He needs to be on the OP, he needs to be in the operation theater as soon as possible. So make sure blue light ambulance you call and you shift to the regional vascular center within 30 minutes. Otherwise, if the patient dies, the coroner will question you. We will assume that when to consider an aneurysm repair. Someone has come, he's stable, he's have abdominal pain and he's come. If he's asymptomatic and it is an incidental finding what you are having, what you do. If it's asymptomatic and if it's an incidental finding, then you will see what is the size of the triple A. If the size of the triple A is more or equal to 5.5 centimeters, then requires an immediate attention to the surgeons, vascular surgeons, and they need to operate it. He's asymptomatic, but the size is more than 4 centimeters, or have grown by 1 centimeter in 1 year, or grown by 0.5 centimeters in last 6 months. These are the three circumstances. That means it is rapidly growing. It is more than 4 centimeters, but it is rapidly growing. For example, 6 months back, he had come, it was 3.6 centimeters. Okay, it has been documented. You are able to see the old records. Now you have done a scan and it has turned out to be 4.2 centimeters in last 6 months. It has grown from here to here. So it has increased by 0.6 centimeters over a 6 months. This is an indication because it is more than, sorry, greater than 4. At the same point of time, it has enlarged by 0.5 centimeters over the 6 months. It can be 1 centimeter over 1 year also. That is an indication. Any size it might be. It might be just 3.1 centimeters. If they are symptomatic, for example, abdominal pain, they requires an intervention. Which are the interventions? Open surgery is preferred in men who are less than or under 70 years. More than 70 years in women of any age. Endovascular, that means they pass the catheter and try to repair it, is preferred. In an elderly man that is more than 70 years or in a woman of any age, endovascular aneurysmal repair is preferred. Aortic dissection. We know large arteries have innermost layer known as intima, the middle layer is known as media, the outermost layer is known as adventitia. First, the innermost layer gets dissected. So there is a passage which is formed. Over the time, the media also gets disrupted and a false lumen has been created. This false lumen, what will happen? Through this false lumen, the blood might enter back into the heart. So there is a regurgitation. So aortic regurgitation can be seen in these persons. So that is one of the classical findings on the examination. Along with it, this blood can enter into the space, pericardial space, resulting in pericardiac tamponade. So most of them who present to the emergency department dies because of cardiac tamponade rather than the dissection itself. But if the dissection passes and dissects the outermost layer, what will happen? The adventitia, the outermost layer gets, the blood will start pouring out into your thoracic cavity and the person will die. He will never present to the emergency department if it's a complete dissection. Usually inner and the middle layer which are involved, the adventitia and the media which are involved, they present to the emergency department. If the outermost layer is involved, then it is gone. If adventitia, the outermost layer is gone, it's gone. Intima and media, if it is involved, then it's fine. If the outermost layer is involved, it will bleed profusely because of the high pressures in the aorta. They'll lose the complete intravascular volumes within minutes. They will die. Nothing can be done. Usually, they do not even present to the emergency department. So, various classification. So, most of the time, these patients present, you get an CT CT iotogram, you will get it done. CT iotogram, depending on the involvement. If it is arch is involved, only arch is involved, then you call it as a type 2. Here you can see only arch is involved. If arch and descending aorta is involved, that means ascending arch and the descending aorta is involved, then it is known as D Bakes 1. D Bakes 2 is only ascending is involved. Sometimes arch might be involved, but never and descending aorta is involved here. Then it is known as D Bakes 2. Whenever the ascending aorta is involved, it's okay, Stanford. So D Bakes 1 and 2 comes as an Stanford's A, proximal involvement of the aorta. Whenever there is only the descending aorta is involved, then it is known as Stanford's B or D Bakes 3. Why is it important for us to know the classification? Because when you call an cardiothoracic surgeon, he will ask you, what is the classification? Why is it important for an cardiothoracic surgeon? It is important for an cardiothoracic surgeon to know because if the ascending aorta is involved, he will do an surgery. Definitely, there is no question about it. If only, I'm repeating it, if only the descending aorta is involved, most of the time it is in conservative management. Most of the time, I'm telling it's not always, most of the time it is a conservative management. For this reason, he will ask you the question. If they ask you the question, you need to be aware of the classification. You need to tell them. Otherwise, he'll think you do not know anything. What are the predisposing factors for aortic dissection? High blood pressure, one of the important. Connective tissue disorders, especially Maffitt syndrome and Ehlers-Danlos syndrome is important. Coarctation of aorta seen in pediatric age group. They would have diagnosed, unlikely to present. Cocaine abuse, another important point you need to be aware of. At least remember this four. How do they present? They present an retrosternal pain. It is kind of a ripping retrosternal pain. They will be presenting to the emergency department. Acute onset, severe pain, they will be having it. Sometimes even the pain might be mild. Even with an paracetamol, the pain can disappear. Okay, that is an proximal, that is something you need to be aware of. Most of the time, it is quite severe pain what they are presenting with. If it is radiating to the intrascapular region, it basically indicates that descending aorta is getting involved. As I told you, pain may not be there in 10% of the patients. They might present with a syncope. They might present with some other unusual findings like in doom of death. He'll come and say, I'm gonna die. I feel like I'm gonna die. That kind of, or stroke-like symptoms they might be presenting. Why stroke-like symptoms or why an syncope is seen? It is mainly because of the supply of the brain comes from the arch of the aorta. So this is the arch of the aorta. The first branch what you are having is brachiocephalic artery. Then you have an left common carotid artery. Then you have an subclavian artery. So these are the main branches what you are having. Brachiocephalic what you are having, then you have a common carotid artery, then you have a subclavian artery. You need to be aware that if the dissection is involving only this region, that means basocephalic artery is involved, but common carotid especially the subclavian artery is not involved. At only that point of time, the differentiation between the right upper limb and the left upper limb blood pressure will be seen. If the entire arch of aorta is involved, this differentiating factor between right and left upper limb pain will not be seen. You need to be very much aware of. So they can present with an hypertension or hypotension. Inter Interarm blood pressure differential greater than 20 is highly suggestive, might not always be present, because if the entire arch of the aorta is involved, then brachiocephalic artery and the left subclavian artery both are involved. So the blood supply to both the arteries is both the limbs is reduced. Left upper limb and the right upper limb, it is reduced. So no point. So again, another factor you need to remember here is the right arm blood pressure should be lower than that of the left arm blood pressure. Remember this. Okay, don't get confused in the exam. New diastolic murmur, that is the aortic regurgitation. I explained you that can be present. Cardiac tamponade, most of the time they die because of the cardiac tamponade. Classical triad with an dilated distended neck vessels, hypotension, and muffled heart sounds can be present in these patients. Neurological deficits, because common carotid artery common carotid arteries basically gives away the internal and external carotid arteries. They are the main blood supply for your brain. Asymmetric pulses can be seen, especially femur, if you are comparing with that of the carotid. Investigations wise, ECG is not helpful. It just shows STT wave non-specific changes. X-ray sometimes might be there. Mediastinal widening can be seen. As you can see here, mediastinal widening can be seen. Sometimes there might be effusion in the left intrathoracic region. Basically, effusion, what you're seeing here. Again, if you're seeing an effusion, large amount of blood is lost, he may not survive. Okay, loss of contour of the aortic knuckle here can be seen, not always. Globular heart also, it's not very specific. Transthoracic echocardiography can help you. 50% of the cases are picked it up, especially the type A one. Type B one, it is difficult to pick it up because it is the descending aorta. You may not be able to visualize on an echo scan. Transesophageal, it has very good sensitivity. CT scan, especially of the mediastinum, might be helpful. CT iotogram will be helpful here. Here you can see here, this is the false lumen, this is the true lumen, this is the classical finding. This is the arch of aorta, which has been cross-sectioned. That's why you're seeing aorta here and aorta here and here. Cross-section. That's why you're seeing, in both you can see there is a false lumen and a true lumen which is present. CT scan is the best one. Iotography can quickly get it done if the patient is stable, or else you will depend on the indirect science, clinical examination, and transthoracic echocardiography. Transesophageal may not be possible to get it done in the emergency department. Remember that the echo finding, the classical echo finding is pericardial effusion along with aortic regurgitation. For aortic regurgitation, you need to have a dynamic image, so unlikely to be tested. They might directly give there is a murmur. Aortic regurgitation murmur might be present. So they can give you there is an diastolic murmur was is present in this patient. Sometimes if it might be a vague presentation, how to know it is a vague presentation? What you do at that point of time? Someone might say, I have a chest pain. It is retrosternal chest pain itself, you might say. Gastric reflux can present with a retrosternal chest pain. Can we always label them as an aortic dissection, get an CT iotogram? It might be an overkill for the patient. So what we do an scoring. In scoring, we see any high-risk conditions, predisposing factors, high-risk factors, what we have learned. Mainly the Marfan syndrome, aortic wall diseases, or recent aortic manipulations, or any known thoracic aortic aneurysms this patient is having, or family history of any aortic diseases. If any one of this following is present, one score he'll get. If he has 2, 3, 4 also, it's fine. It is just in one score what he'll be getting. High risk pain feature, the classical presentation of the pain. Sudden onset, severe in intensity, and radiating to the back. He describes it as a tearing or a ripping kind of pain. High risk features are present. That is evidence of perfusion deficit, or any evidence of a new murmur that is suggestive of an aortic insufficiency murmur, basically aortic regurgitation murmur is present, then you get one more point. If the patient is having 0, it is low risk, what you will do at this point of time? At this point of time, you can just get an D-dimer done. If D-dimer is on the lower side, you rule out an aortic dissection. But if it is intermediate and high risk, then you need to get a CT iotogram if the patient is stable, or else you need to involve the cardiothoracic surgeon and start resuscitating. How do you resuscitate the patient in the emergency department? First, ABC you will manage. C is important. Hypotensive, IV fluids, if blood is available, give blood. If hypertension, use labetalol. Try to reduce the blood pressure around 100 to 120. There it was 90, here 100 to 120 what we are targeting. Sometimes labetalol itself may not be helpful. They'll be having hypertensive emergencies. Labetalol itself may not be helpful. At that point of time, along with the beta blocker, you can add up and glycerol trinitrate, which is a vasodilator, can be added up if one of the beta blockers is not working or it is not effective. But remember that only using an vasodilator is not recommended because it can trigger and reflex increase in heart rate, reflex tachycardia, what we call it. That's why you should have an beta blocker to make sure the heart rate never increases. As I told you, type A, Sanford's classification, most of the time requires an surgical intervention. Type B, most of the time doesn't require an surgical intervention, conservative management. Again, the call is not taken by us. They will be taking the call. The cardiothoracic surgeons will be taking the call. What about if the patient has an cardiac tamponade? How do you treat an cardiac tamponade? Surgery is the thing what you need to do for an cardiac tamponade. Why we are not doing an pericardiocentesis here? Let me explain why we are not doing an pericardiocentesis in this patient. For example, okay, we will imagine this is the fluid and this is the heart what is present here. This is the fluid. You put a needle here and start aspirating. What will happen? The blood is coming down because there is a dissection. The blood is entering into the into the pericardial space. So you can keep on aspirating here. It will never stop. If you just leave it as such and do not aspirate, at least it can cause an tampon effect and it might stop and blood entering into the pericardial space. If you continuously aspirate, the blood will continuously enter into the cavity and he will die. That's why pericardiocentesis is not preferred. Okay, the preferred one is to do an thoracotomy, basically involve the cardiothoracic surgeon, do an thoracotomy. That's why always remember thoracotomy is the first option. For example, you do not have a cardiovascular surgeon available in your hospital for some reason, is sick or something, it is not available. At that point of time, you can try and pericardiocentesis because that's the last resort what you're having. Somehow it stops, somehow a clot has formed, somehow it stops, he might survive. Otherwise, he'll die eventually if you leave it as such also. So it's better to try it. So always remember thoracotomy, basically surgical intervention is preferred. That's why we always involve the cardiothoracic surgeons. Acute limb ischemia, it can be an acute or it can be an acute on chronic or acute limb ischemia after revascularization. So it was an acute limb ischemia. There was some clot or chronic limb ischemia. They are vascularized it, used a graft, and graft has got rejected and occluded. That is known as acute limb ischemia after and revascularization. He had a chronic limb ischemia. Chronic limb ischemia classically presents with a claudication pain. What is claudication pain? Whenever I walk, I get severe pain in my lower limbs. I take rest and the pain disappears. That is a classical history of a claudication. That is known as claudication pain. This claudication pain was there since months together and suddenly now I have a severe pain in my left lower limb. For example, left lower limb. Then it is suggestive of an acute on chronic. Directly, you can present with a severe lower limb pain. It might be left side, right side. Most of the time, it will be unilateral, not bilateral. Remember that acute limb ischemia carries a very high risk of mortality and morbidity. Clinical features are very much similar to that of the compartment syndrome. What happens in compartment syndrome? There is acute compromise of the vascular supply, that is an arterial supply. Same thing happens here also, same thing you're suspecting. So the first earliest sign is pain out of proportionate to the apparent injury, what you'll be seeing. Along with it, you might see paresthesia, some muscle weakness, pulselessness is late, paralysis is very late, pallor is again late signs. While you're examining, it's a good habit to look for any arrhythmias he is having. For example, AF, which is throwing out the emboli and which is causing the acute limb ischemia. Some carotid bruit, atherosclerotic bruit present in the carotids can also cause and throw out an emboli. Document all these things. A heart murmur or aneurysm is already present. Peripheral pulses, if you're not able to feel it, confirm it with a Doppler, handheld Doppler bedside. There is a classification which you need to be very much aware of because the management plan depends on it. That's why the vascular surgeon will ask you the classification. Rutherford's classification. Class 1, motor and sensory part of your foot will be completely intact. So he'll be able to wiggle his toes and the sensation over the toes will be intact. Type 2A, In type 2A, again, he'll be able to move. There is no compromise in the motor, but sensory loss over the toes can be seen. Or sometimes there may not be any sensory loss. Most of the time, some numbness, some changes in the sensory loss or paresthesia might be present over the toes. Type 2B. Type 2B, there will be partial paralysis. So complete movements of the toes will not be present. And there will be loss of sensations, might be complete loss of sensations, or at least toes, definitely there will be loss of sensation. Type 3, profound paralysis. He's not able to move his toes at all. And profound anesthetic, completely no sensation. If you touch him also, there will be no sensation will be there. Why is it important? Because if it is category 1, you can wait and get an imaging done in the morning. For example, he is present in the midnight. You can wait and get it done imaging in the morning where motor and sensory are intact. Type 2A, you get an imaging done immediately where motor is intact, some sensory deficit is present. Type 2B, he needs to go to immediately to the theaters where there is partial paralysis and sensation is significantly lost. You need to directly go to the theaters. For example, on the way to the operation theater, you can scan it, or you can scan in the operation theater, then get an scan done. But theaters, you need to go as soon as the sooner you vascularize, the better it is. Type 3. Type 3, what happens in type 3? The tissue is already dead. He's not able to move his toes at all. Complete motor deficit is present. So if you revascularize for this individual, there will be massive release of potassium, creatine kinase, myoglobins, high lactate levels, and oxygen free radicals. This might be life threatening. That's why we'll not revascularize. We'll usually amputate the limb. That is the management plan. But how do you manage in the emergency department? This is the classification more for the vasculars, but you need to be aware of this classification. In the emergency department, for an acute limb ischemia, airway, breathing, if something is there, circulation, resuscitate if required. Most of the time, it's just the limb involved. So circulation wise, they'll be intact. So first step is, as this patient is stable, according to a generic rule, you'll be involving the specialist. After involving the specialist, second step is giving an heparin, unfractioned heparin. You'll be giving 5,000 international units, bolus IV. That's it, along with the symptomatic treatment like analgesia if required. Infusion, you will decide if the surgeon says, I'm not thrombolizing, I'm not revascularizing, just start on the infusion. I'll come in the morning and see. That time you'll start. So this infusion is on the vascular surgeon's advice, not on yourself. So remember, the treatment plan is first is vascular surgeon referral. Second is everyone gets a shot of 5,000 international units of IV unfractioned heparin. Popliteal aneurysms tend to accumulate in the thrombus, back of your knee. There might be a swelling. Do not get confused with the Baker cyst here. Okay, Baker cyst is different. Baker cyst, usually, if it bursts open, the entire calf will be swollen. Here, only a mass can be seen. Okay, this is known as popliteal aneurysm, and this mass can be sometimes sometimes pulsatile. So most of the time, if you can auscultate, if you can palpate it, it will be more pulsatile. It will not get compressed, unlike an Baker cyst. Urgent referral to the urgent referral to the vascular specialist needs to be done. This is mainly because the aneurysm can accumulate large amount of thrombus here, and they can throw this thrombus into your systemic circulation, causing various infarctions, including stroke. Subclavian steal syndrome. First, the normal anatomy you need to be aware of. Okay, this is a brachiocephalic artery, the first branch of the arch of the aorta. Brachiocephalic artery divides into a common carotid artery and the subclavian artery. Common carotid artery just goes up. We are not worried about the common carotid artery. Forget about the common carotid artery. The subclavian artery will give a branch which is known as vertebral artery. Left-sided subclavian artery also gives a branch which is known as left vertebral artery. So right and left vertebral artery combine together. So there is a connection between an left subclavian artery and a right subclavian artery. Okay, they combine together to form an they combine together to form an posterior circulation. Okay, basilar artery usually they form it. Now, what happens in subclavian steal syndrome? In subclavian syndrome, there is a stenosis or something which is causing obstruction in the subclavian artery, left-sided subclavian artery. So what will happen? The blood which is from the right-sided subclavian artery enters into the vertebral artery, then again it enters into the left vertebral artery and will supply the left subclavian artery. Okay, that's why the left upper limb blood supply is actually from the right subclavian artery through the right vertebral artery, entering into the left vertebral artery, entering into the left subclavian artery. So let me repeat this one so that there is no confusion what you are having. Because of the obstruction in the left subclavian artery, the blood from the right subclavian artery goes into the right vertebral artery. It's a normal circulation. From right vertebral artery, it enters into the left vertebral artery, which is abnormal. Then it enters into the left subclavian artery and supplies the left upper limb. Okay, so what happens? The blood what you are getting in the left upper limb is very minimal what you are getting. So once you use this arm, start using this arm, requires more. The left arm, if your left upper limb, if you start using it, it requires more blood supply. It will suck more blood from the right vertebral artery into going into the left vertebral artery, getting into the subclavian artery. What will happen? The blood supply to the basilar artery will reduce drastically. If blood supply to the brain is reduced, you'll have an syncope. So the classical history is whenever I use my left upper limb, I have a loss of consciousness. That classical history, whenever someone presents with, think of subclavian steal syndrome. Nothing can be done in the emergency department. You will be referring to the vascular surgeons. Raynaud's disease. It is the most common vasospastic disease. That means it causes vasospasm. There is no underlying cause. We do not know why is it happened. Sometimes they say predisposing factors like emotions or cold can predispose to it. They classically have initially pale. So only one single digit or tip of the digit can go completely pale. Sometimes all the digits can go or multiple digits or the palm gets paled. Completely pale it will be. It involves only the palmar and the digital arteries. It cannot be seen in the foot. It is only in the palm what you're seeing. So this completely pale, after some time, the spasm disappears. Once the spasm disappears, the deoxygenated blood what is present will appear bluish in color. Over the time, this deoxygenated blood, that is nothing but cyanosis what is present, will start disappearing and it will become pink in color. This is known as pale blue red phenomena what will happen in this. There is no underlying disease at all. You cannot make out anything. Why is it happening? Usually it recurs by itself. So self-limiting it is. Sometimes a gangrenous changes might start appearing if it lasts for a longer time. So dip the limb into warm water or keep it warm because cold is one of the precipitating factors. You can try with an oral calcium channel blocker. Sometimes a topical nitroglycerin can be applied over the web spaces. Over the web spaces, especially from the dorsum, not here. From the dorsum side, you can start applying some of the jelly which is available. Nitroglycerin can be applied. Topical nitroglycerin, it will cause vasodilatation. That can be tried. This is known as Raynaud's disease. There is something known as Raynaud's phenomena. Similar presentation with an underlying disease, then it is known as Raynaud's phenomena. You commonly see it in scleroderma, rheumatoid arthritis, and SLE. We'll take up the questions now before we enter into the recall questions. Diverticulitis, as I told you, you need to depend on the NICE guidelines to make a diagnosis. Age is 50. Anyone above 50 years, you'll start doing a bedside ultrasound scan. It's not that above 65 or above 95 only I'll see and AAA. Endovascular repair is a 70. Painful conditions, yes, they will have pain because it's a vascular compromise which is causing the whenever there is a vascular compromise, the patients will have certain amount of pain. Pain will be seen. Now we'll enter into the recall questions. A 34 years old male has brought to the MS department in an ambulance. On arrival to the ED, he complains of severe abdominal pain. Gives a history of multiple episodes of vomiting since morning. He is a no. There are no comorbidities. On examination, the abdomen is diffusely tender. X-ray is given. What is the most likely underlying cause? Let us see X-ray. X-ray, what I can see is bowel loops are central, and there is a white line which is across the bowel loop, suggesting often small bowel obstruction. In small bowel obstruction, most commonest cause for small bowel obstruction is strictures. Strictures is not given as the cause. Second most common is an hernia. So we are picking up as an hernia as the right answer. Elderly female present to the emergency department with an abdominal pain and bloating. There is no significant past medical history. History of constipation, abdominal pain. Since couple of days is present. Vital parameters grossly stable. Tachycardia is present. Diffuse abdominal tenderness on examination. X-ray is given. What is the most likely diagnosis? X-ray. The bowel loops are distended more peripherally. What you are seeing. Hostile lines also can be seen, suggestive of a large bowel obstruction. Which of the following hernias? They are given all the options as hernias which will cause a large bowel obstruction. Only lumbar hernia can cause large bowel obstruction. Remember that only lumbar hernia causes large bowel obstruction. A 68 years old male present to the ED with complaints of a chest pain radiating to his back. He feels he is having an heart attack. The nurse at the triage has given painkillers which has reduced the pain. On examination, you have the following trends. Blood pressure is on the higher side. There's some amount of tachycardia, diastolic cardiac murmur. You need to always think whenever there is pain radiating to the back, it must be an aortic regurgitation what the patient is having. T-dimer is high, tropi is high. What's the most likely diagnosis? Remember that tropi can be high in aortic dissection. Do not get confused with an myocardial infarction. With D-dimer being high, with an aortic murmur presenting, with an classical chest pain, it is an aortic dissection unless and until proven otherwise. So answer is 5. A 60 years old female present to the ED department with complaints of an abdominal pain. She is a known case of hypertension and she is on hydrochlorothiazide for the same. Her vital parameters are within normal limits. Laboratory investigations are shown. The significant laboratory investigation is hypokalemia. What is the most likely diagnosis? Again, this is a classical picture of small bowel obstruction because bowel loops are in the central. It looks small because 3 centimeters is not like 5 or more than 5 centimeters suggestive of large bowel. So it is a small bowel obstruction what the X-ray is suggestive of. So it is an functional I'm suspecting because of hypokalemia. Hypokalemia is one of the causes for functional bowel obstruction. Functional bowel obstruction is also known as paralytic ileus. Remember, paralytic ileus is also known as functional bowel obstruction. They mean one and the same. A 79 years old male present to the emergency department with complaints of respiratory chest pain relating to the back. He is profusely sweating and looks ill. You receive him in the resuscitation bay, connecting the cardiac monitor. Monitor shows tachycardia and high blood pressure. You are strongly suspecting aortic dissection. Which of the following can you expect in an aortic dissection? Ventricular rupture. Do we see in? No. Anterior wall hypokinesia is seen in anterior wall myocardial infarction. Abdominal aorta more than 4 centimeters. We are not talking about triple A here. We are talking about dissection. So abdominal aorta, you can just forget it. Pericardial effusion, can you see it? Yes, you can see in pericardial effusion, which can progress into cardiac tamponade and cause an death. Right upper limb blood pressure less than that of, no, it should be opposite. Right upper limb blood pressure should be more than that of the left upper limb blood pressure. So the right answer here is the fourth one. A 70 years old male came to the emergency department with complaints of severe pain in the left lower limb. He is a known case of ischemic heart disease, hypertension, and hyperlipidemia. On examination, the limb is pale and cold to touch. No peripheral pulses are felt, so we know it is an acute limb ischemia. Only a general surgeon is available in your hospital. What will be the next step? In acute limb ischemia, the first step is always referred to the vascular surgeons. So is there a mention of vascular surgeon here? Call a vascular surgeon and refer. Yes, this is the right one. The second step, step 2 is to give heparin 5000 international units intravenous bolus. Elderly female present to the ED department with complaints of multiple episodes of vomiting. Elderly, she is associated with an abdominal pain. She is a known case of hypertension and diabetes. On examination, the abdomen is soft and non-tender. Ultrasound examination shows aorta measuring about 4.4 centimeters. The rest of the X-ray is unremarkable. Sorry, it should be an ultrasound scan if I'm not wrong. The rest of the ultrasound scan should be unremarkable. Her lab reports are within normal limits. ECG and tropi are normal. You are made a diagnosis of gastritis. What is the next best step in management of this patient? Denies abdominal pain. So it is in gastritis which is causing the vomiting here. Vomiting is usually not associated with AAA. So yeah, incidental finding of an aorta of being aorta, that is descending aorta, abdominal aorta, being of size of 4.4 centimeters. So anything more than 3 centimeters, we label them as an aneurysm. So this one should be closely monitored. So ultrasound scan should be done every 6 months to make sure it is within the normal range. If it is 5.5 centimeters or enlarging drastically, requires a surgical intervention. So you need to advise them to follow up with the GP. Urgent vascular surgeon opinion will not be required here because it is only 4.4 centimeters. Admit no, reassure and discharge no, because continuous ultrasound monitoring is required. Urgent endoscopy, again, not required here. A 70 years old patient came to the MS department with complaints of abdominal pain and vomiting. On further questioning, he says he had vomited, has not moved the bowels. That means constipation. Whenever there is a triad of abdominal pain, vomiting, and constipation, think of bowel obstruction. Since 3 to 4 days, the pain is worsening since morning. Is a known case of diabetic nephropathy with an GFR of 30. On examination, the abdomen is tender with guarding and rigidity. What is the best initial step in management? Guarding and rigidity. Whenever there is a guarding and rigidity, we are thinking of an perforation. So obstruction has led to an perforation. Perforation has led to an peritonitis. So perforated bowel will have air under the diaphragm. So initial best investigation is just to get an erect abdomen or erect chest X-ray done with the diaphragm covering it, because you can see air under the diaphragm. Again, you can argue why not get an CT scan with an contrast done, mainly because the GFR is on the lower side. So might go into complete renal failure. So initial test is always to get an erect abdominal scan done. Patient with pain, CT abdomen better than an erect X-ray. CT abdomen with an IV contrast is always and better in an abdominal obstruction, but you can get it done only if the patient is stable and the creatinine levels in the normal range. An elderly patient, a known case of CKD stage 5 on regular hemodialysis, has an right upper limb AV fistula, that is arteriovenous fistula. Usually they get it done for the dialysis. Was shifted from the dialysis center to the emergency department, the nurse at the triage has noticed that there is an absence of palpable thrill over the AV fistula. AV fistula, when they're working, they'll have a palpable thrill. If it is not working, that's when there will be absence of palpable thrill. Vitals are within normal limits. What you will do? It's better to get a scan done. Okay, because this patient is stable, you do not know what is causing loss of AV fistula thrill, because the patient is completely stable. What is causing? So get an upper limb Doppler scan done. Once you have the cause, you can involve the vascular surgeons. An elderly female was brought to the MS department in an ambulance. She complains of severe abdominal pain. On further questioning, she says she has not opened the bowel since 4 to 5 days. The patient has started vomiting in the emergency department. So constipation, vomiting, abdominal pain, bowel obstruction. Observations are given here. Slight amount of tachycardia is present. Tender, but no guarding and rigidity. IV fluids here. Started analgesia has been given. Erect abdomen is shown. What is the likely diagnosis? The erect abdomen, what you can see here, has a classical coffee bean appearance. It is suggestive of an sigmoid volvulus. So this is a diagnosis of sigmoid volvulus. Large bowel obstruction has happened here. A 33 years old male, a known alcoholic, has been to a bar where he has been bench drinking. It has led to multiple episodes of vomiting. Initial vomiting has the food particles. Later, they have noticed that there is some amount of blood is present. Now he has developed severe chest pain, difficulty in swallowing. X-ray has been given. What's the likely diagnosis? So what is the finding on an X-ray? Mediastinum looks fine for me, but I can see air here in the soft tissue. Air here in the soft tissue with the classical history where initial vomiting had only food particles, only food. Then later on, it was associated with the blood, suggestive of an ruptured esophagus, which is also known as Bohas syndrome. Because if esophagus gets ruptured, the air also gets air also comes out of the esophagus, resulting in subcutaneous emphysema. So this is a classical history and X-ray of an Bohas syndrome. Aspiration will not cause subcutaneous emphysema, so it is not an aspiration, and aspiration will not cause blood, so it cannot be aspiration. An elderly patient was brought to the emergency department in an ambulance. He complains of severe abdominal pain. He is a known case of peripheral vascular disease and hyperlipidemia. Abdominal examination, unremarkable. The patient pain doesn't improve even with analgesia. Blood gas has been given. Lactates are crazily on the higher side. A patient has a metabolic acidosis because pH is on the lower side. Bicarb is on the lower side. What is the most likely diagnosis here? Examination was normal, but he has severe pain, lactates on the higher side, suggestive of an mesenteric infarction. So next thing is, in last September that similar question had come up. They had not mentioned mesenteric infarction as this. They had mentioned as ischemic bowel. So will the ischemic bowel will be the right answer here? Yes. Ischemic bowel is also a right answer because ischemic bowel is a broader term used for to just suggest that there is a vascular compromise. So one of the subtypes of ischemic bowel is mesenteric infarction. So yes, this was the right answer in the September 24 diet. A 23 years old female present to the emergency department. She has noticed blood in the stool since few days. She denies any associated pain or use of illicit drugs. She has no comorbidities, is on regular medications, vital parameters are within normal range. What is the most commonest cause for the presentation? What she has presented with blood in the stools, along with it is not denies any associated pain. So painless. We need to be aware it is a painless blood what is present. Which one of the following can cause painless bleeding? Diverticulitis, present with an abdominal pain. Anal fissures, severe pain on defecation. Anal abscess, quite a bit pain usually it doesn't have. Ischemic colitis, again associated with the pain. Hemorrhoids, especially internal hemorrhoids causes bleeding, they will be pain free. So the right answer here is the first one, internal hemorrhoids. An elderly male presents to the MS department with left loin pain radiating to the groin region associated with an hematuria, but it is an elderly, so we are always thinking N triple A, not an uritic calculi. He is a known case of arthritis and BP, and on further questioning, a history of dizziness is present. You administer analgesia according to the local protocol. Ultrasound scan shows an aorta diameter of 3.5 centimeters. No fluid was seen. What's the next best step? Triple A is ruled out because there is no free fluid. No, triple A doesn't depend on the free fluid. It depends on the diameter. It is more than 3 centimeters. It is an triple A for us. So no. Reconsider diagnosis. No, it is an triple A. We are not reconsidering. Urgent surgical reference for decision making. Absolutely right. Urgent surgical reference should be required. To be more clear, it is a vascular reference what is required as a first step. CT abdomen immediately. CTQB outpatient. Outpatient, no. First, we need to always involve the surgeons first, then decide if the patient is stable, then you decide to get NCT abdomen, that is an iotogram done. So the right answer here is always involve the surgeons first. So because this patient is symptomatic, presented with abdominal pain and abdominal aortic, sorry, abdominal aorta diameter is 3.5 centimeters. A 58 years old male presented to the MS department with a severe right lower limb pain since 6 hours. He is a known case of IHD. Multiple comorbidities are present on examination. Vital pulse are normal. Dorsalis pedis pulse is absent and pallor is present. There is decreased toe movements in the affected limb. What is the next best step? Again, always in acute limb ischemia. Why I'm telling acute limb ischemia? Pulse is absent. Classical history. In acute limb ischemia, whenever the patient presents, step one is always involve the vascular surgeons. So urgent referral to the vascular surgeons needs to be done. Step two is when you will be giving heparin. X-ray they have given, they have asked most likely cause. X-ray is suggestive of a small bowel obstruction because it is more centrally placed. Most commonest cause for small bowel obstruction is adhesions followed by hernia. A 35 years old farmer sustained an injury to the lower limb while farming. He is not known to have any comorbidities. He is fully vaccinated. He complains of swelling over the injured side as shown in the picture. While he was waiting in the triage area to be seen by the nurse, he deteriorates and becomes toxic and febrile. You see him in the resuscitation room and secure an IV line. What is the most appropriate step in the management plan? What are you suspecting here? I want the diagnosis. What are you suspecting here? This patient, young patient, no comorbidities, farmer, sustained an injury presented like this. Very rapidly he has deteriorated. That is itself is suggestive of a necrotizing fasciitis. This is a diagnosis of necrotizing fasciitis the patient is having. In necrotizing fasciitis, step one is always debrided as soon as possible. So involve urgent surgical reference for debridement. This is step one. Followed by step two is giving IV antibiotics. Always step two is IV antibiotics. This we have covered already in dermatology chapter. An elderly patient, a known case of dementia, present to the ED with nausea. She lives in a care home. She refuses to take any oral medications due to nausea. On examination, the abdomen is distended and it is tympanic on percussion. What is the most likely diagnosis? This same question has appeared in September 24 also. Constipation will cause dullness, but abdominal distension can be seen during severe constipation, but constipation will cause dullness on percussion. Small bowel obstruction. Small bowel obstruction usually because of the fluid accumulation in the bowel. That is basically what you have eaten. Because of that, it becomes dull on percussion again. Diverticulitis can be tympanic. Hernia can be tympanic, but usually this doesn't cause an abdominal distension. Here, abdominal distension is because of volvulus, especially seen in an elderly person. So, right diagnosis here is the second one. Elderly patient brought to the MS department. He complains of severe diffuse abdominal pain. He is a known case of peripheral vascular disease and hyperlipidemia. On examination, there is a diffuse tenderness in the abdomen and rigidity. The pain doesn't improve even with an analgesia. Blood gas is in given. Lactate levels are on the higher side. Most likely diagnosis, classical history of mesenteric infarction because of a severe abdominal pain, along with lactates on the higher side. It is always mesenteric ischemia until and unless proven otherwise. A 62 years old female present to the ED with a severe left lower abdominal pain. She is a smoker, a known case of hypertension, diabetes. On examination, left dorsalis pedis pulse is not felt. CT angiography of the left lower limb confirms acute limb ischemia. It is not left lower abdominal pain, left lower limb pain. Okay, remember it's left lower limb pain, not an abdominal pain. So it is an acute limb ischemia. What is the diagnosis is? You immediately refer to the vascular surgeons. Which one of the following is the most appropriate next step? You already referred to the vascular surgeons. That is the step one. Step one is done. Step two is giving heparin. Heparin how much? 5,000 international units intravenous bolus. So this is the right answer here. A 19 years old female present to the MS department with abdominal pain since a couple of days. She is a known case of depression. There is an history of extremely reduced food intake since past few days, and she has some psychiatric issues. Abdominal X-ray shows diffuse tenderness. X-ray is given here below. What's the most likely cause for the finding? X-ray again typical of a small bowel obstruction. Here, what you need to consider here, a small bowel obstruction, we are aware that strictures is most commonest followed by hernia. Can it be functional? Yes, it can be functional, or we need to strongly suspect functional because of reduced food intake. Reduced food intake can cause electrolyte imbalances, especially low potassium levels, that is hypokalemia, can cause paralytic ileus. Hypokalemia, paralytic ileus, what we are suspecting here, because of this additional history what they are given. A 78 years old male was brought to the MS department with a retrocerebral chest pain radiating to the back. Here itself, I'm suspecting as an aortic dissection. The left radial pulse is feeble. You shift this patient immediately to the resuscitation room and connect the patient to the cardiac monitor and secure the IV line. You are strongly suspecting aortic dissection. Which one of the following is seen in the echo scan? Echo scan, pericardial effusion, along with regurgitation, aortic regurgitation can be seen. Those are the two typical findings what you'll be seeing on the echo scan. LV dilatation, it's not very commonly seen LV dilatation, which is seen. It takes time to develop. Some might argue that regurgitation can cause LV dilatation, but it takes time. It doesn't happen acutely. Septal bulging towards the right side doesn't happen acutely. RV dilatation is more seen in a PE, pulmonary emboli. Renal wall abnormalities are seen in a myocardial infarction. Elderly male present to the ED department with a lower back pain. I'm thinking of an again AAA here. A triad nurse has requested you to assess the patient on the resuscitation bay. Patient is hypertensive. You immediately do a bedside ultrasound scan. It is suggestive of an AAA. You, your center doesn't have an vascular surgeon. What is the next best step? Again, the patient is hypertensive also doesn't matter. Still, you will be referring to the vascular surgeons. That is always the first step. Elderly male present to the emergency department with a left lower limb pain associated with, left lower abdominal pain associated with diarrhea. He's noticed blood in the stools. There have been no similar complaints in the past. He is a known case of arthritis and BPH. There's some amount of tachycardia. Blood pressure is on the lower side. What is the most likely diagnosis they are asking here? Whenever it can be ischemic colitis, Can be with the presentation what they are given. It can be diverticulitis. Yes, it can be diverticulitis. Okay. Can it be an CA colon? Yes, CA colon also. It can be an CA colon also, which can is the most commonest cause for large bowel obstruction, and a CA can cause bleeding. But large bowel obstructions will not cause diarrhea, so we can rule it out. Okay, so we are left with diverticulitis and ischemic colitis here. Diarrhea is not seen commonly in mesenteric ischemia, and it is severe pain what they present with, so you can rule it out this one also. But diverticulitis is much more common than ischemic colitis. Diverticulitis, you need to pick it up in these scenarios. I recommend you to pick up in diverticulitis in these scenarios. CA colon doesn't present with diarrhea. You just started your shift and noticed that an colleague fingers appears pale. As shown in the picture, actually in the examination, there was only one finger as this appearance, completely pale, only one finger. Concerned, you ask what happened. She mentioned that it keeps recurring, it keeps coming and going. That kind of language was used. You check her vital parameters, which are completely within normal limits. What is the likely diagnosis? This is a classical presentation of a Raynaud's disease. Another thing is Burgess disease. Burgess disease, you need to be aware of. It is a rare thing. First of all, it is a rare thing, commonly seen in young individuals who are heavy smokers. So, young individual, heavy smoker. Pathologically, if you see, they involve the small and medium size arteries. Usually, small and medium size arteries are there, and it is a segmental involvement will be there. What do you mean by segmental? So, if this is an artery, this segment part will be involved and causes inflammation. This part will be in inflammation. So, segmental. One part is normal, one part is affected, and it causes inflammation. It doesn't cause any atherosclerosis. It causes inflammation. Okay, inflammatory disorder. It causes inflammation. It can produce like any acute limb ischemia. Okay, so in exam, if you have to pick up an Burgess disease, remember that they have to mention you and smoker, and the individual should be young. Then only pick up an Burgess disease. Otherwise, do not pick an Burgess disease. It will not fit in. 88 years old patient with an hypertension COPD AF presents with an abdominal pain. On examination. You notice an pulsatile mass in the abdomen. AAA, you're suspecting, confirmed as in AAA on an ultrasound scan. You contact the regional officers, and decision regarding the surgery is pending. This some amount of tachycardia, hypotension, tachypnea is present. What is the most appropriate next step in the management of this patient? So what you will be doing? It is a AAA. First step for AAA, stable or unstable, is always vascular reference. You're already done. You're waiting for their advice. So each one of this CT aortogram, you cannot get it done because the patient is unstable. So we are ruled it out. In view of comorbidities, start on palliative care. You cannot just start on palliative care. Palliative care is started when you expect this patient to die in next few days to months. You need to expect, and it is a group of doctors which take a call. Still, vascular surgeon, you're waiting for the decision for a vascular surgeon. You cannot just decide on your own and palliative care. You cannot put it on yourself because you're involved other specialty. You're waiting for a decision. Palliative care cannot be done here. So again, you're ruled it out. Start on inotropes. Inotropes you will not be starting. First, you will be doing resuscitation. Resuscitation, you have two fluids available. One is blood, one is crystalloids. Blood is preferred over crystalloids in this situation. So blood will be given for this patients. So right answer here is blood transfusion. Last few questions which you have discussed has appeared in the last stats. A concerned mother has brought her 5 years old child to the emergency department. She reports that whenever the child urinates, she notices a swelling around the penis resembling a balloon. The child is otherwise healthy with immunization up to date. What is the appropriate management plan? So what is the diagnosis here? It is an phimosis what she is talking about. Phimosis, here you can see the foreskin not retracted back. So whenever urinated, because of the small opening, it gets bulges, and slowly the urine gets dripped out, and this bulge will disappear. If there is no acute urinary retention, we just reassure them, educate the mother initially, and discharge them. Unless and until you are suspecting an infection like a urinary tract infection, then urine routine will do. If antibiotic is required, you will take a call. So you'll just reassure and educate. You'll be educating about the personal hygiene here. Is the poor hygiene, which is the most commonest cause. Poor hygiene leading to an infection usually causes it. So need to be clearly explained about the personal hygiene here and discharge them. So reassure, explain, and then discharge. So that was the end of the recall questions. One of you had